Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Today, we are meeting a cancer survivor whose cancer journey started when he noticed a change while eating. Ken O'Brien felt that sometimes food just wasn't going down like it used to. Thankfully, he mentioned it to his doctor, who ordered a scope, which then found a tumor. It was right at the border between his esophagus and his stomach. That part of the body is also called the GE Junction. Cancer in the GE Junction can sometimes be very similar to gastric cancer, or sometimes similar to esophagus cancer, or sometimes a little bit of both. Ken O'Brien is with us in studio today to talk all about it. We're going to hear what it took to survive stage 4 cancer that was really deemed inoperable. So good morning to you.
Good morning.
Good to have you. We are also learning from his oncologist, Dr. Anup Kasi. He is joining us virtually this morning. Dr. Kasi is an expert in cancers all along the GI tract. Dr. Kasi, we have spoken on this program before about cancers of the colon, the rectum, stomach, and pancreas. And we're happy to now be learning more about this GE Junction today. So thank you for being here.
Thank you, Jessica. Thanks for having me.
All right, so Ken, take us back. We're going to go back to the summer of 2022. You were sometimes, not always though, feeling like when you ate, like it just didn't feel right. Explain what you were physically feeling.
Sometimes when I was eating, I felt like food was getting stuck here. Generally, nothing's in essence serious. I take a couple of sips of carbonated water, maybe a burp, and everything was fine.
Yeah, I've felt that, kind of like right there, like you feel like you press on the bone in your chest and you're like, oh, there's something in there.
Yeah.
That kind of felt kind of pesky and just wouldn't go away.
Correct. It would happen periodically, but then it would just be an incident.
So any other symptoms, like heartburn feeling? Was there cough, fatigue involved?
And actually, but surprisingly, no other symptoms. It just, those things would happen periodically. And I had some concern, but I didn't really think it was anything.
So thank goodness you mentioned something at one of your regular checkups. Good for you getting your regular checkup, by the way. How did you get from mentioning something to your doctor to finding out that this was indeed cancer?
Okay, a little bit of an interesting story. So we were scheduled. My doctor had indicated that an endoscope would be appropriate, and scheduled that for me. I went and had the endoscope, and as we were in the area recovering from anesthesia, the doctor came in and said, "I've got some bad news. You're going to need an oncologist." And even though they took a biopsy, and even though they hadn't got the results, it was my understanding that he knew that it was going to be malignant. So from that point, we started in initial shock. We walk out of just a routine endoscope thinking, man, I have cancer. And so I'd say we spent the weekend researching, worrying, kind of in shock, but then went through the recommendation, got a CT scan, an endoscopic ultrasound, and a PET scan. And that led us to the initial diagnosis from the other medical center.
So there was this kind of a shock, but was there an ounce of relief, like, okay, we at least know what this is and we can start getting after it? Did that hit at some point where you thought, let's get on top of this and get going with what the next step is? Yes,
admittedly, but I'd say that first weekend, kind of shock, and then we probably made that mistake that maybe even Dr. Kasi has mentioned. We went to Dr. Google, and Dr. Google would provide more scary scenarios, although you have to research on the internet, so it wasn't too bad, but we were just concerned. And then we had a trip, and we ended up, again, even in that area, he said, well, you can't really be gone for more than 2 weeks, already anticipating that I was going to need some sort of treatment. So it took a while to process, but we forged on.
And we've all been to Dr. Google. I think Google is not all bad. You just got to know where to look, and then you got to follow up with the right doctors. And I understand, so this all happened at a different hospital, but you decided to seek that second opinion here at the health system. And I understand you got a different diagnosis, though, when you came here. Walk us through that story.
Okay. Well, my initial stage, from our understanding at the other medical center, was stage 3 plus immunotherapy, chemotherapy, radiation, potential for surgery, resectable. I'm not pronouncing the term, but it may be operable and curable. We wanted to go with, get a second opinion, and chose KU in consultation with some research, also discussions with friends who had good stories about KU, and that's where we met Dr. Kasi. His analysis was stage 4, and at that point, I mean, 3 or 4, it's still not the best number, and didn't think it was something that we would allow me to would be operable. And then I started on immunotherapy and chemotherapy at KU.
And you did a good job explaining that. I'm going to bring in Dr. Kasi because he might be able to get a little bit more technical on that diagnosis and the exact stage of Ken's cancer. Can you explain that further, Dr. Kasi?
Yeah, so when we diagnose cancers, we label them as stage 1, 2, 3, 4, depending on the spread of the cancer. Generally, stage 3 cancers would be when the cancer spreads from the GE junction, and in cases like Ken's, to lymph nodes around the GE junction, or what we call as regional lymph nodes. But what had happened in Ken's case was there were lymph nodes that were far away from the GE junction, in and around the GE junction area. They were in the back of the abdomen, called the retroperitoneum. So that counts as a faraway lymph node, as a distant lymph node, what makes it as a stage 4 cancer. Though I must say it was a limited stage 4 in Ken's case, but at the same time, the location of the lymph nodes being next to major blood vessels in the back of the abdomen, which go up and down the body, it's really hard to cut out those lymph nodes. It's a very high risk surgery or a procedure, and hence it was deemed unresectable.
So is it considered an aggressive cancer?
Yeah, the GE junction cancers do tend to be an aggressive type of cancer. Of course, there are different types of subtypes of GE junction cancers or esophageal cancer. You have a squamous cell type, adenocarcinoma type, and the neuroendocrine type. So depending on the subtype, that aggressiveness can vary to a certain extent, but overall, it is an aggressive cancer.
So Dr. Kasi, help us understand a little bit more about this part of the body. I think many of us folks who aren't GI experts like you think of esophagus and then the stomach. And Ken and I were even saying, we were kind of just thinking it was just kind of that kind of down that front of your chest. So tell us what makes this junction special.
Yeah, no, that's a good question. So GE junction is a critical part of your GI system. As you can see in the picture, there's the esophagus, the food pipe through which the food goes through, into the stomach, which is the stomach, or also referred to as the gastric part of the body. And then right at the junction is the GE junction, basically. And this is a specialized ring of muscle that acts like a valve. So it allows the food to go through the food pipe into the stomach, but then it doesn't allow the stomach contents and the acid to go back into the food pipe. So thereby preventing, reflux, all the stomach acid coming into the food pipe and the damage that can happen from that. So any kind of dysfunction to the GE junction can lead to reflux disease, reflux changes that can then lead to what we call as Barrett's esophagus, and inflammation that could be a precursor for GE junction cancer in that area, or in the food pipe esophageal cancer.
And you kind of touched on it. And Dr. Kasi, we talk about all types of cancers here on this program, but what makes esophageal cancer different or unique as far as its symptoms or its ability to be caught early?
Yeah, so I would say a fair number of esophageal and GE junction cancers, we can try to capture them at an earlier stage. Depending on where it's located, the majority of the patients do notice reflux symptoms, difficulty swallowing, pain when swallowing. From time to time, they could also have regurgitation of the food, throwing up, and sometimes even hematemesis, which is vomiting of blood. Also some constitutional symptoms like loss of weight, loss of appetite. So those are some of the major presenting symptoms. Depending on the location, if it's located in the stomach, which is much lower than the GE junction, then at times They can have early satiety, feeling full easily, food not passing through, causing a lot of nausea, and often those are the cancers that may present at a later stage.
So why wasn't surgery an option?
Yeah, so in Kent's case, basically it's the location of the lymph nodes. So since the lymph nodes that were far away from in and around the GE Junction area in the back of the abdomen, that's located right next to the major blood vessels called as the aorta and the vena cava, which carry blood to up and down from the heart to other parts of the body. So going there to the back of the abdomen, next to the major blood vessels, it can make the surgery next to impossible to cut out those lymph nodes. It's a very high-risk procedure, which can lead to, they cannot cut out the major blood vessels of your body, right? So that's the reason.
Not worth the risk for sure. So Ken, you went through weeks and weeks of chemotherapy. We know some chemo regimens are harder than others. How did you handle yours?
Well, I think I'm very fortunate. After you have that first meeting with the pharmacist and you go through all the potential risks and symptoms, you walk out of there, wow, this could be pretty bad. And fortunately, I know everybody reacts differently to chemo. I had some of the major symptoms I had were the neuropathy, in the hands and feet, some resistance, tingling to cold, and everything that I had metal tasted metallic, and so some of my food taste changed. But actually, the side effects from the chemo, I think I had 10 cycles, and in every 2 weeks, and mostly there were maybe only a couple days that I needed to maybe stay close to home, where I didn't feel good or just needed to be there. And so surprisingly, I think I was fortunate that the side effects were much less than I expected. I expected a lot worse.
Well, and you also received some immunotherapy, the brand name Keytruda. We've heard the name, Dr. Kasi, and we hear more and more patients say that they've received Keytruda. Why was this offered to Ken?
Yeah, so, the treatment landscape for GE Junction cancer, esophageal cancer, gastric cancer has kind of changed and evolved with the advent of immunotherapy entering into treatment of these upper GI cancers. We check for what we call as biomarkers, looking at kind of the molecular and the genetic makeup of the tumor. So some markers like HER2 and PD-L1. So these are predictive markers that help us make treatment decisions. So in Ken's case, these markers were positive. And that's how we were able to combine chemotherapy along with immunotherapy and a targeted therapy. So the immunotherapy component was Keytruda in his case, and the targeted therapy called as trastuzumab or Herceptin that targets HER2 protein, which is a growth factor for some of these cancers. So that was the treatment regimen that we used for him. And, we're really seeing good responses in cases like this.
And Ken, I understand this immunotherapy affected your liver. How so?
Well, eventually, when I was going in for the for the immunotherapy treatments, this was after the chemo was complete, and I think Dr. Kasi we decided to continue with the immunotherapy as part of the continued treatment, and then in a routine, as most cancer patients all know, you get your blood drawn, and in the routine blood draw before one of my sessions for Keytruda, they found my liver enzymes were way too high. I had no symptoms, I felt fine, but that day we stopped the Keytruda.
Ken, we talk a lot about this show. We talk about being your own advocate and knowing your body and knowing when to speak up. Just what's your message to people who are at home listening and may know something just isn't right? Oh,
well, I think in that case, both, as we talked earlier, with your family physician, or if you're in treatment here or in treatment with your oncologist, just let them know. You say, hey, I feel like this. Is that, and nothing's too small. It isn't, don't be afraid to at least ask and say, hey, I'm sure, like I would do, I'd say, I'm sure it's nothing, but hey, I noticed this. And so I think that would be one message, is to just just ask. There's no dumb question. Dr. Kasi was very good at that too. Sometimes he probably would. I figured you were thinking, boy, that's a dumb question, but no.
No dumb questions, right, Dr. Kasi?
Yeah, no question is a dumb question or a silly question. Some patients may not want to talk about side effects or symptoms with concerns that we may change treatments or the intensity of the treatment, but that's not really the case. I mean, we may have some solutions for those problems. So yeah, no dumb question at all.
And you need patients to speak up and tell you what they're thinking and certainly what they're feeling, right, Dr. Kasi? It's just it's a team effort in getting people across the finish line. And I know, Ken, through all of this, you have gotten immense support from your biggest cheerleader, Sue, your wife.
Right.
Tell us a little bit about her and what this has been like.
Well, I think, again, as we were discussing today's visit, we focused back to that July day, and we were just, shocked. But she was able to be my eyes in these appointments, in deciding where to go seek treatment. She was my eyes and ears in those meetings with Dr. Kasi, with everybody, to get a feel. Maybe she would think of a question that I would forget to ask, or we'd come home and discuss what we just heard. So one, she was a great helper. And then two, I think important to me is when I was going through the chemo, and as I indicated, I maybe only had a couple bad days, but I'd have the tendency to just maybe kind of sit around. And she was the one who would be, come on, let's go walk. We would walk, and not a lot, but maybe 4 times a week, at least 30 minutes. And come on, let's go to the fitness center and walk, or let's go take a walk. So she helped motivate me, I think, to stay active. I might have had a tendency to be a little less.
Let's give a shout out also to your daughter and stepkids. I noticed some photos that we just ran through. How important were they through all of this?
Yeah, they were, I think, and we'll get to talk about friends too, but they were just, we told them, they were concerned, they would call, check in, and they were able to just, make sure that I knew they were there for me. And I think one thing important, and a group of friends, which I think you're getting to that, but especially our whole group of friends locally were, a good resource, and provided a resource probably that I didn't even think I needed.
And they made some T-shirts, is this what I understand?
Yeah, and as another set of friends, this OB Strong, OB was my nickname. These were friends that I've had since 4th grade from different parts of the country. We received a package, and there were these OB Strong T-shirts when they heard about my diagnosis. And so that just was...
That's pretty darn cool.
Yeah.
4th grade friends? 4th
grade, and they're all, nobody here locally, and they would send me pictures from either their travels with the OB Strong shirt on. And I just want to add that the local friends, I think what I find really important was that our local group of friends, people would say, well, we'll add you to our prayer group, or good thoughts, but then also they gave me, they were always here for me when I needed to talk, but then more importantly, were also here for me when I didn't need to talk. And that was also very helpful.
That speaks very loudly. And I like you sharing that, because there's people maybe who aren't going down the cancer journey physically, but there's supporters out there, and sometimes they don't always know how to be there for somebody. So when you share these stories, they're listening and going, hey, I've got somebody going through that, so I'm going to put them on the prayer list, or I'm going to bring something by, or I'm just going to sit and listen.
Yep,
all those important things. So what did you find out and get the news that you were in remission?
The initial, I don't want to get too medical with Dr. Kasi, but I would say it was of July or August of this year, after a CT scan and endoscope, I believe. Dr. Kasi told us that I was in, I think called it clinical remission. And then the complete remission was January of this year, is my understanding.
Well, let's bring in the doc on this one. So Dr. Kasi, what's the difference between clinical remission and complete remission?
Yeah, I think, in terms of these terminologies, I guess what, we meant to actually discuss is clinical remission and pathologic remission. So clinical remission is looking at the patient's symptoms, imaging studies, lab values, and see if we have any evidence of cancer. And if we don't have any evidence of cancer there, then we call that as a clinical remission. Whereas pathologic remission is, in addition to the clinical remission, also not finding any cancer on the surgical specimen. So typically these are reserved for patients that do undergo surgery and we don't find any residual viable cancer. Everything has been taken care of. So that would be a complete pathologic remission. However, in Ken's case, since it was unresectable cancer, what we ended up doing was repeating the endoscopy and looking for any abnormal tissues and see if we could do any biopsies. And we didn't see anything abnormal there. And that's why I call that as a complete remission for Ken. And I mean, this is an excellent response. So even without surgery, now we can say that Ken is in remission and cancer-free.
All right, we like the sound of that for sure. Be sure to ask your questions. You can use the chat on YouTube or Facebook. We are also on the X platform. You can email the Medical News Network. All that information is right there on your screen. And while you send in your questions, we will get a check on the COVID count. As of Monday, we had just 4 inpatients with COVID-19. And a reminder to you that the big change coming up tomorrow, after May 1st, we are going to stop sharing the COVID count on this program. We consider this a positive milestone. The public emergency ended 1 year ago. And as of today, hospitals will no longer need to report COVID cases to the Center for Medicare and Medicaid Services. You, of course, will still see Dr. Dana Hawkinson, including on tomorrow's episode of Open Mics with Dr. Stites. He will not be a stranger. You will still see his face. Well, let's get to some questions this morning from our viewers. All right, does heartburn or acid reflux increase my risk of esophagus cancer? Dr. Kasi, what should people know about that?
Yeah, so I would say it depends on the severity and the duration of reflux. So if it's something that is constant, persistent, then yes, it could lead to damage of the lining of the esophagus or the GE junction, and that could lead to what we call as reflux disease, and over time that can lead to inflammation called Barrett's esophagitis, which then becomes risk factor for cancer. So if you are having a reflux of heartburns that is not resolving, continuous, then yes, you need to bring that up with your primary care physicians.
Dr. Kasi, is there a genetic component to this type of cancer?
There's a subset of upper GI cancers that could be genetic, especially if there's a strong family history of cancers. There are syndromes, hereditary type of syndromes. So one of them is called as Lynch syndrome, for example. So those kind of conditions can give rise to cancers, even without precursor lesions like reflux disease or heartburns or Barrett's esophageal changes.
Jeremy has a question for you, Ken. Did that feeling of it being different when you ate food ever go back to normal?
Yeah, I really haven't had any of those symptoms since the endoscope in July. So between the treatment and then even the endoscope, I guess they said they stretched a small part. No, I have not had any of those symptoms since.
Question was, how did you decide where to seek treatment? We talk again about the importance of a second opinion. How did that process go for you? Well, we just kind of reached out to a group, especially a group of our local friends, and explained to them my diagnosis and the decision we were needing to make, and they shared just their stories with us. And I would offer that the other hospital, we didn't hear anything bad, but we heard good stories from our friends about KU, some of their KU cancer experiences. So that weighed heavily on our decision. So I think between just a little bit of research, I would say that the designation that the KU Cancer Center has was important, but we had just heard, I think we had heard got a good feedback from friends that made it a difficult decision. In the end, made it kind of an easy decision to go with Dr. Kasi. Yeah, you knew the designation. You did your homework. Good for you. Good for you.
And if I can pitch in, Jessica, so I just wanted to add, yes, I mean, Ken's right. I mean, we're a comprehensive NCI designated cancer center, and that gives us, access to groundbreaking novel treatment options. And in fact, Ken was in one of the clinical trials with a targeted pill form of treatment along with immunotherapy. So that helps, provide these novel treatment options that could potentially have a benefit for our cancer patients.
Yes, we're glad Ken landed here. Dr. Kasi, what's the big takeaway from our chat today?
Yeah, I would say, of course, watch for your symptoms, especially if you're having dysphagia, which is difficulty swallowing, pain when swallowing, and a long-standing history of heartburns or reflux changes. Also, if you're noticing loss of weight, loss of appetite. So those will be some of the red flags, along with, abdominal pain. So if you notice these symptoms, then please discuss that with your primary care physicians and try to see if we can detect this at an earlier stage and take care of it. And also, next generation sequencing, which is molecular and genomic testing of biopsies that helps us identify targets based on which we can personalize cancer treatments in this era of precision medicine and personalized medicine.
Dr. Kasi, we always appreciate your insight. Thanks for being with us today. Ken, what's the big takeaway from your story?
We covered some of it, which was always ask your regular doctor when you have symptoms. Don't be afraid of a second opinion. When you get involved in the cancer treatments, reach out to family and friends. They can be a wonderful resource. Very important, we've talked about stay active, be positive. I'm more of a glass half full kind of person, so I think we were active, positive, keep fighting. I think that's very important. And finally, then also thank you, Dr. Kasi.
It's my honor and privilege to get to know you and take care of you, Ken. I think your positive attitude and plays a big part in the outcomes for your treatments and coping with all of this.
Okay.
Thank you both for being with us today. Thanks for sitting here with me. It's been a
You're
pleasure.
welcome. Yeah.
Thanks to our viewers for joining us as well. We'll see you back here tomorrow at 8. COVID is a concern, but not a crisis anymore. As we wind down our COVID count, we reflect on 4 years of helping the public understand what the pandemic really means. I'm Jessica Lovell on the next Open Mics with Dr. Stites. Vaccine expert Dr. Greg Poland joins Dr. Stites and Dr. Hawkinson to assess where we are and what happens next as pandemic evolves to endemic. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.